Alrighty, good evening, everyone, or good afternoon from wherever you're tuning in from across Canada or abroad. It's nice to see you again on another continuing education webinar. You might see that my background isn't an NSWOC one today, and that's because I'm proud to be here representing both NSWOC, or Nurses Specialized in Wound, Ostomy, and Continence Canada, where I'm their Chief Operating Officer, and I'm also representing our Canadian Pressure Injury Advisory Panel. And I wanted to wish everyone today happy Worldwide Pressure Injury Prevention Day. And it's only fitting that today's topic is going to be a very important conversation and a great dialogue and discussion on thinking beyond the Braden score, revisiting pressure injuries in cancer patients, a call to action. We have an amazing guest speaker with us today, Lilibeth Acero, who's going to lead the discussion. But before I get started and introduce her, I want to say thank you as well to Smith+Nephew for their partnership, for the support in pressure injury prevention and management. And we really look forward to this discussion today. You might recognize Lilibeth, who helped present earlier on this year in February. Some people might have been on our pressure injury prevention bundled approach for success webinar. So you may recognize Lilibeth. She is currently serves as a hospice team manager at VNS Health in New York City and previously spent 15 years as the skin integrity nurse coordinator at Nassau University Medical Center, where she developed the Acero Kurtz perioperative skin bundle, achieving remarkable success in reducing operating room pressure injuries 3 years in a row. She's also a diplomat of the American Professional Wound Care Association, a member of UMA, or the European Wound Management Association, and continues to collaborate closely with long-term care facilities across Brooklyn and Queens, focusing on risk management and pressure injury prevention. Her work, insight, and leadership make her the perfect person to guide us through the topic today. And I wanted to remind everyone that we are recording today's session. So if you have to head out early, or if you want to share this with your colleagues later, we're going to make that available early next week. Same thing, everyone online today is going to receive a certificate of attendance early next week too. I can see everyone in the chat here has already started to use it. You're introducing from where you're coming from. Please feel free to do the same. And we're going to be interweaving some of the questions for today's session in and throughout the presentation. So if you have questions, if you have ideas, you can also use that Q&A box, and that'll make it as easy as possible for us to go through those conversations. So without further ado, Lilibeth, thank you for being here again on such an important day in the global pressure injury prevention community, and I'll turn it over to you.
Thank you so much. Thank you, everybody. Good evening, everybody. Good afternoon, wherever you are. And I want to thank everybody for this opportunity, especially for Wendy reaching out to me for this topic from Smith+Nephew. I would like to thank everybody who's here and in collaboration with CPIAP over there. Thank you so much for this opportunity. I do need your attendance, because this is something that's new. It's very bold topic, but it's something that might give you some interest in focusing on in your practice. So I want to welcome you to this new topic, very exciting one, thinking beyond the Braden score, revisiting pressure injuries in cancer patients. This is a call to action. And I just want to add on my introduction. I am a wound care specialist of the VA New York Harbor here in Brooklyn. So my objective for this is hopefully I will ignite some interest, or maybe give you some idea, or inspire you to crack open something new. This is my first objective is to understand the limits of Braden scale score on a specific cancer patient, a specific patient, which is our oncology patients, review gaps and challenges of our current practice, investigate other pressure injury risk factors, which is a systemic review, very extensive systemic review on our cancer patient, remembering the unique needs of cancer patients and their skin. And then hopefully we can formulate the next step to pressure injury prevention. And I would like it to be intervention driven, not just a risk assessment scale, but we have to add intervention along with it. And then what we think we can do in the future. So I would like you, if you have anything to say, add on to this. I wanna tell you ahead, I'm not the expert on cancer patients, but I know I saw something that any one of you who's in this practice might be able to agree on, or maybe do something about it. I'm going to need everybody's help on this one. But this is a very interesting initiative that you can maybe find it interesting to do. First of all, cancer patients appear to have higher risk or incidence of pressure injury than general hospitalized population, but we could never know because we never separated them when we do our hospital-wide incidence rate. In hospice or advanced cancer patient, it had been seen that there is a 17% in the Italian hospice cohort. We don't have one in the US, but this is quite something like a useful benchmark that people have been using. But we have been trying a goal to zero. That's our goal. So what would make cancer patient different? Why would we benchmark 17%? That is very high for me. So in ICU or oncology ICU settings, incidence may vary widely. Some reports show in Brazil, which is 29.5% on oncology, which is odd to me because that is very high. And I don't have any US number, but I do have a number which is 2020. I'm going to say this is the number 2022. There is a single article noting a prevalence of pressure injury in cancer patients. This is a study from I don't know if you agree with me, if you knew about it, have you read about this? At the Toronto region, Canada, in a palliative program reported that among cancer patients, there's a prevalence. So that would mean patients with and developing a new one, well, pressure injury was 22.4%, which is so high because we're talking about percentage. That is very high. So what does the implication of this topic? So that we will emphasize that oncology or hospice population have distinct risk profile that is beyond Braden. Example, we have cachexia, we have radiation damage, we have immunosuppression, which is not always captured by general pressure injury incidence data. And because national US large-scale data specific to cancer patients is very, very limited, highlight the data gap and the need for oncology, like specific surveillance and reporting, we don't have that at all. I know our regulators, our leaders, our researchers are so busy doing updating policies, protocol, guidelines on what is very obvious, but oncology has been pushed back to the back burner. And I felt like these are different population. They stay at home. They don't usually get to the hospital all the time in the entire span of their cancer diagnosis, their treatment, and everything else. They deserve something that is really specific to them. So we use the broader hospital incidence data, which is so high, it's 8%, to show how oncology patient may exceed those averages. So background is for Braden scale, though widely used, this is very intelligent tool for people that is of general condition, clinical condition, inpatient condition, may underestimate the risk of oncology patient. There might be a Braden scale score that is above 16 or 17, but they are high risk for developing pressure injury or some type of skin breakdown. So cancer-related factors like cachexia or treatment-related tissue changes or radiation, fibrosis, and immunosuppression is not reflected at all in the Braden scale. And then pressure injury in cancer patients often arise despite moderate or very low risk score in Braden. So let's start with the systemic review. It's from the beginning. Clinical condition of cancer patients are way different than everyone else. So this is something I want to show, that a lot of these systemic changes on a cancer patient, newly diagnosed, started chemo, started radiation, on a treatment program, they have either perfusion problem, oxygenation problem, or dermal epidermal junction problem, which is, we knew that all of our pressure injury patients have those problems. But what set them apart from all others, or what happened to their body while during early diagnosis, late diagnosis, and while on treatment. So both chemo and radiation primarily damages dividing cells, and it's non-selective. It doesn't choose just the malignant cells. It also does the normal cells. right? And it targets the bone marrow, mucosa, skin, GI, and hair follicles almost everywhere, from the inside organ to the tips of your fingers. It affects everywhere. So it had a multi-system stress response. The oxidative damage is so far and that's so huge that it breaks the DNA. Then you have the inflammatory cytokine release, microvascular problem, and then impaired regeneration or wound healing. That's just the very cellular level. Now, when we talk about cardiovascular system, they have endothelial damage while having this treatment. There's inflammation, there's fibrosis, and reduced capillary density. And when you have that problem, there will be perfusion problem, oxygenation problem. And then when you have perfusion problem, you have tissue hypoxia, acute hypoxia, or chronic, and then it become anoxic, and then become apoptosis. And then you add a coagulopathy as well. Coagulopathy clots the end arteries, then you can have ischemia. The bleeding tendencies that we thought was D-type could have been just because of coagulopathy. Now, respiratory problem, we know we have radiation pneumonitis, we have fibrosis. There will be less elasticity of that lung muscle to expand in order to breathe in and out of that very essential oxygen exchange. And then we have chemo-induced toxicity. And then because of that, the impact would be reduced oxygenation. So please feel free to stop me if you have anything to say. Decreased cellular repair, fragility of the skin, and then tissue necrosis, which is making the patient at risk for pressure injury. Now, what happened to GI? We all know they're going to be vomiting, there is diarrhea, there is less uptake of the needed nutrients, the needed calories for wound healing, for homeostasis. All this is impacted. And there is an altered microbiome. That's very important. We need this normal flora in our gut to control infection. But because of that alteration, there is that problem that's not going to be able to fight invading microorganism, and then there's going to be sepsis risk for the patient. Now, the impact of the skin, if you cannot absorb those nutrients, the protein and vitamin deficiency, there will be impairment in collagen synthesis and eventually wound healing. So now we have talk about all the systems that's going to create problem: oxygenation, perfusion, wound healing, rebuilding of tissues is the main problem of our oncology patient. Now, what happened with hematology and our immune response? There will be much reduced immune response. There is myelosuppression, reduction of WBC, which we all know that's needed to fighting invading microorganism. There is neutropenia. And then anemia, low oxygen delivery because of the red blood cells delivers oxygen to the end arteries. You have thrombocytopenia, again, fragile capillaries and easy bruising and bleeding even with the slightest trauma. And then with fragile capillaries, you're gonna have those macrophages seep out from the arteries going to the interstitial spaces. Then you have edema, then you have bleeding also. So these are the things that's going on. You add with the neurologic system, peripheral neuropathy, for one thing, due to medication, decreased sensation, then proprioception, not knowing your position in bed. You don't even know. I don't even know. If I am that patient having that problem, I would not be able to know that I'm already sliding. And you have shear force injury in both of your buttocks you really don't know about because you have very decreased sensation or feeling of where you are in relation to the surface. Autonomic neuropathy, the lack of blood perfusion. And then the impact, of course, is reduced pain sensation. You don't know that you're laying for 6 hours, 5 hours of that cap of the syringe. You don't know if you're laying on one of the tubing. You don't know that you're laying 6 hours. The nurse was not able to turn you on the side. You don't know, you don't feel it, but you already have something brewing in your sacrum. So this is the problem of neuropathy and proprioception. And tegumentary. So we have radiation dermatitis. I did have that patient 3 weeks ago, admitted to the hospital with radiation dermatitis. And he was not eating well because it was located by the side of the neck to the back to the chest. So he's guarding, he's not turning his head, he's not chewing well, so he's not eating well. He doesn't have any problem with swallowing, but because of that dermatitis, that's loss of elasticity of the muscle on his neck, so he's not eating. So he was with us for like 3 weeks, and that dermatitis had healed up before he got discharged. It's amazing how simple treatment could really turn miracles, because they do have this problem. It comes and goes. It doesn't mean that it was healed and then it's gone forever. It comes and goes because of the status of the oxidative responses of their body. Chemo-induced skin reaction. There is palmar plantar blistering that we thought it's bullous pemphigus, but it looks like it doesn't, but it's actually a reaction to chemo. And barrier breakdown, the loss of sebaceous gland and sweat gland, and they have very dry, fragile skin. Okay. Now, with that being said, there will be impairment in fibroblast activity and collagen synthesis, which is important in the closure or healing of a wound. So, compromised skin resilience and prolonged or even delayed or wound healing when you have this type of issues. Now, what happened in endocrine and metabolic is thyroid suppression, there is fatigue, decreased metabolism, and eventually deconditioning of the patient. Chronic steroid use, we all knew, would blunt inflammatory and healing responses. And then cachexia is going to cause some muscle wasting, lack of adiposity, which reduces cushioning of the body, and then exposing this bony prominence to even to a slightest friction or pressure, causing a skin breakdown. So there is a very weak musculature and with poor nutrition. So again, major risk factor for pressure injury. And the renal system, there is electrolyte imbalance. We do have a patient. I was so proud of this patient that is a cancer patient, already on treatment, admitted to us for dehydration, because as you all know, there will be a problem on the renal system, and he becomes so edematous, anosarca, but with good care, patient didn't develop anything, but this is one of the issues. So when you have edema or the anosarca, we all know that we already have problem on the dermal epidermal junction. There's already a separation of that layer. So we haven't seen it yet, but we know we already have a problem. Once with that skin blisters, we knew that it's going to happen because of the edema. Hepatic problems. So there is, of course, hepatotoxicity also. And with that being said, there will be a reduction of protein synthesis of albumin. With that being said, also, it's going to be hypoalbuminemia, which is what we think will impair wound healing or delay wound healing. So there's a lot of things we have to check on a patient on a treatment of chemo or radiation, or a cancer patient that's walking around. They are a walking high-risk patient with or without the use of a Braden scale. Musculoskeletal system. So you all know this radiation fibrosis, a myopathy. There's a loss of elasticity of the muscle. So there's reduction of functional ability, weakness, immobility, increased pressure duration, would prefer not to turn, too weak to turn, and then pain and fatigue and decreased mobility is compounding pressure injury risk. So with all that being said, after chemo and radiation, the body is in actual state of metabolic and vascular stress. Okay, so the body is in constant catabolic state. Every organ system contributes to the patient's vulnerability to skin breakdown, from perfusion failure to impaired healing, from angiosomal end arteries, lack of perfusion, to an inability to build muscles, or the lack of collagen or fibroblast accumulation. So this is why standard Braden scale underestimate the risk of our patients in oncology. So therefore, a comprehensive risk assessment should include metabolic, should include vascular, should include neurologic, and the treatment-related parameters. So in summary, the systemic impact, as you can see in all of the organ system of the patient, is interwoven between hypoxia to anoxia or to impairment of skin repair. So you can see a vascular, microvascular injury, perfusion. Respiratory, fibrosis, hypoxia, perfusion. GI, malnutrition, cachexia, impaired skin repair. Hematologic, you have anemia, poor healing, infection risk. Neurologic, neuropathy, sensation, pressure relief is not good. Skin, dermatitis, and fragility. Then we have endocrine, that's in constant catabolic state. When that happens, you have fatigue. In catabolic state, you have mitochondrial dysfunction. And of course, you're going to have cell death. And then you're going to lose muscle mass. You're going to lose adiposity. You're going to lose the capacity to heal or build up collagen and fibroblasts. You have renal problem, we have fluid imbalance, which causes tissue edema. So now we have dermal epidermal junction problem, and same thing with hypoalbuminemia. And then just the literal deconditioning of the body because of all this, that is the systemic problem of the patient. So if I have to put them in a risk category, pathophysiologically, to summarize them all, I would like, if you have an opinion, you can let me know. I would like to start with cancer stage, right? There's a stage 1 to 2, then there's a 3, then there's a 4 to terminal. So I knew that my cancer patient in stage 1 to 2 are active patients. They're mobile and they are receiving treatment. They go to their own treatment clinics. The primary mechanism that might lead to pressure injury would be the treatment-induced skin injury, right? And then likely the presentation would be localized skin irritation or dermatitis. So it kind of like a low risk. So at this point, I'm not using Braden scale. I'm just looking at their clinical status. And then cancer stage 3, this is now progressive disease. There probably would be weight loss. There probably would be fatigue. And then malnutrition, that's the mechanism that would lead to pressure injury, immobility, and vascular compromise. And likely the presentation of a breakdown will be a stage 1 and 2, and it might not just resolve easily. So I'm going to say the patient risk level is moderate, right? Now, cancer stage 4, and terminal, likely at this point in time, patient is bedbound and likely cachectic and multi-organ decline. Skin failure could follow. There will be hypoxic episodes or more episodes or chronic hypoxia and immobility or marked deconditioning. And then you might easily develop from 1 to 2. It could develop fast at 3 and 4. Very quick. And then we think it's Kennedy terminal ulcer if the presentation suggests it is Kennedy terminal ulcer. Then the patient is high risk. So that when I had to summarize them all, but I do need everybody's expertise. Probably this is correct. Probably this needs some changes, or it needs to be investigated in each criteria. So the limitations are gaps. Why do I want this as a call to action? Because oncology-specific tools, we have pressure ulcer scale for oncology patient, which is there online, and the other one is not there. I couldn't get any documents about it. But while they were promising, it had actually limited breadth because it was taken from or adopted from or along with in conjunction of the Braden scale. They may not include key oncology-specific domains, such as the treatment-related skin fragility, such as severe malnutrition, or the tumor burden alone, the immunosuppression or metabolic stresses, right? And the device or catheter or related skin risk on oncology patient if they are inpatient. So those are the gaps on what we have out there. It doesn't actually reflect the actual patient clinical status. So because of those gaps, I would like to encourage this team of experts to revise, to refine, and develop an oncology specific risk assessment scale that is intervention driven. So many studies report that general tools like Braden, Norton's have lower predictive validity on oncology settings. For example, guidelines note that risk assessment scale in general have low sensitivity and specificity in many settings. So lack of large-scale multi-center oncology-specific validation also on comparative study and the review notes, none of the studies actually reported cross-cultural validity and stability measurement error for the oncology tools. So the implementation of the gaps, even when oncology-specific tools exist, clinical practice may still rely on general tools because, like it's what we call like it's muscle memory. It's easier to remember. I know Braden, let me do Braden, but it doesn't really give justice to our patients' unique clinical challenges. So this is my call to action. In 2016, I was actually able to get a copy of what they have started as a cancer patient editorial publication is developing a new adverse pressure ulcer assessment tool. This is great, actually. They have started something that would have been really good for cancer patient. But the missing link is that they have not came back and give us the actual one. So it said at the bottom end here, yet current risk assessment tools have not advanced in line with improved prognosis and changes in demographics of the cancer population. It is therefore essential that clinicians and academic work together to investigate and assess current risk assessment, which is great. And then they're working together on a new tool, which they were going to share, but it hasn't been, there's no report of them sharing a new tool. So that would have been a good start, but it wasn't done. Okay. So in their publication, they said, since the time of Florence Nightingale, we have known about the risk of pressure ulcers to patients, but have we really integrated new treatment regimens, radiotherapy, chemotherapy? See, before I even read this article, I have those questions already in my mind. These were not reflected on those risk assessment tool. So I got excited when I found this article. But unfortunately, there was no follow-up on this one. So my call to action is let's try to reevaluate assessment tools. Let's try to come together another time next year and see what we come up with in our own practice. Because to me, I don't want to rely on the researchers and the big people out there to do the work that I am doing right here at the bedside. A lot of people do the policy, create policy, make changes. They are so far removed from the bedside. So I would rather have things done right at the patient nurse junction. This is where we can do the work because there will be slight difference that you can see that I cannot see from this distance, right? So we can try to reevaluate assessment tools and forget about Braden. This is a different type patient population and try to integrate oncologic and metabolic parameters that we have discussed. Promote interdisciplinary collaboration between oncology, wound care, palliative. You can create a committee to do a tool that is intervention driven for this type of patient population and adopt some technology that we have that had had a real life evidence. The use of 5-layer silicone foam dressing have come out excellent in my practice. And the use of thermal imaging, I'm going to tell you, don't need to buy expensive one. I have used in my practice, I bought one that is FDA approved for use in the hospital and military grade. Actually, I bought a thermal imaging just to look into the difference of the thermodynamic that is also a huge factor in developing pressure injury, which is often just a small topic in biomechanics of pressure injury. Thermodynamics is always like a little bit of a topic, but it's actually, to me, before a pressure injury, before even this biomechanic issue happen, there is thermodynamics, there is heat, there is moisture before you change that skin texture, that it's gonna be not so resilient with friction. Before friction, there's gotta be heat, there's gotta be moisture, there's gotta be something before friction create friction. So that's how I understood that. So adopt this technology. If you have the perfusion mapping, wonderful. If you have thermal imaging, very good. But I know everybody has silicone foam dressing. I would like to make that a habit as part of your intervention driven prevention protocol. Educate clinicians on recognizing non-traditional pressure injury prevention in cancer population. You know, you are there. You are the one seeing these changes. You are the one. There's a slight difference in this patient. This a little bit of change in the conditioning. Why do all of my patients with this type of skin breakdown have this type of issues? So kind of put that together, the common denominator, and create a prevention tool that is intervention driven. So if we are to evaluate and compare what we have out there, because that's where we should begin. We have a tool, but what's wrong with it? Or nothing's wrong with it, but it's not specific to my cancer patient. So there's a pressure ulcer scale in oncology that's been out there, but as you can see, the factor that it had is almost the same as Braden scale. There's immobility problem, there's incontinence, and then there's moisture, right? So same thing with Braden, but it never once mentioned anything of the clinical difference the patient had as oncology patient to other patients. The oxidative stress that they go through, the catabolic state that they go through, the problem with wound healing, with collagen, with all these things, perfusion is not reflected in here. So if I am to write something, just to summarize what I think should be added on an oncology pressure risk assessment, I'm going to say triad because I put them together in a group. So cancer patient at highest risk for pressure injury typically have 1, reduced tissue tolerance. 2, we have impaired perfusion and oxygenation. And 3, we have deconditioning or immobility and sensory loss. So clinical tip, if I have to tell you about Braden, anybody with score above 17 in Braden may still be high risk for skin breakdown. So these are the patients that's been on chemo or ongoing chemo or radiation treatment within the past 14 days. That could be another criteria. Had albumin level that is suboptimal, very visible cachexia, loss of muscle mass, no adiposity, has radiation dermatitis or neuropathy already, or is in an active treatment or palliative stage. So just to trigger some challenges to everybody. So Braden limitation focuses on mobility, moisture, and nutrition, but it did not focus on metabolic stress, treatment toxicity, or skin fragility. We have thermotherapy, chemo, radiation that can cause this microvasculature and cellular damage, which is very essential in developing 100% pressure injury. Then the end of life changes, skin changes, the Kennedy terminal ulcer may be misclassified, maybe misused, maybe underreported or overused. When we see a problem, oh, it's end of life, it's scale, oh, it's Kennedy. Are we just using that as an excuse and not doing really what we can do to the patient? So, so just to give a little bit of a picture of what I think I saw that you can improve, right? Doing the bedside, especially if this is your practice and this is your expertise. Mobility problem can be a low risk. Then you have perfusion and neuropathy, which can be low to moderate. And you have advanced stage or chemoradiation treatment that is moderate going to high. And then we have immunosuppression. I don't know. That probably is it. I could have hit the target, or I may not have hit the target. So I need everybody's expertise to add on to it and to create something that can be used by our nurses at the bedside or at home. Oncology and cancer patients don't stay in the hospital. That's why Braden Scale is not for them. They stay at home. They are in the community. They live normal lives. They go to work. They go to family affairs and parties, and they are so apart from our patient as an inpatient oncology patients. Now, oncology pressure injury risk model. This is what I have put together so far. And in my long research about oncology patient, I have hit a roadblock because I don't have so much data and no one have done so many researches or publication. All I know is during treatment, there is a problem with connective tissues. And then all these systemic issues come together as a bundle is very indicative of a high risk patient developing pressure injury. But if I have to think of the intrinsic factor combined with cancer specific factor, I might be able to come up with an intervention bundles, but I'm not sure if that is the right um, criteria, but let me just go over with you. So the green ones is low risk, and then the yellow ones are moderate, and the pink are high risk. So I put frailty, cancer stage 1, mobility or slightly impaired as low risk. Then I did moderate risk for BMI extreme, which is cachexia. We have cancer stage 2. Then we have pain limiting movement. I put that on moderate risk. And then we have comorbidities, pressure injury history, of course, cancer stage 3 and higher on chemo immunotherapy, cancer stage 4, impaired perfusion and albumin and hemoglobin problem as high risk. That is also another way of doing a risk model, other than the triad that I gave on the prior slide. So when breakthroughs get lost into oblivion, so this idea, I hope, is not just a rudimentary idea that sprout out and then get lost into oblivion, but there is really something that is valid about it that needs all of us to work on it together to come up with a solution and how to set our oncology patients apart from the general population. So how did this breakthrough that in 2016, London were able to put in a publication and forgot about this whole thing years later, right? There was limited validation funding. That could be one thing. There were dominance of generic tool. Like I said, it's like muscle memory. Let me just do Braden. Braden is fine. Cancer care evolves faster than tools. Tools takes years. It takes patience. It takes tenacity. You could be doing it yourself alone. It's very isolating. But once you come up with something that really works for you, it's really worth all those isolation. Then there is low visibility and publication barrier. I only found one publication, right? Reimbursement problem and policy gap, because everything falls within the where the hospital at as far as reimbursement. Then the clinical reality. Nurses adapt instead of replace. We adapt. It's adapted from. We always say that, adapted from this. We're too scared to start on something. But the good news, though, is there is a renewed interest today in oncology, skin safety, and precision risk prediction using AI, electronic health records, and predictive analytics. But would you like AI to do your numbers? Would you like AI to read on your patient's data and say, oh, you can do this protocol? We have so many brilliant minds that can do something more than AI. So these newer models may revive and integrate those earlier ideas like the PUSO into modern data-driven algorithms. But then again, those are adapted from Braden scale, right? So the new era of bundles should create a shift in algorithms predictability. So what's the CMS perspective on pressure injury risk toll? What do they want in order to pay the hospital, right? To reimburse the hospital of the care that was given. CMS strongly emphasize, I don't want you to get discouraged when I say this. That's why I put this first, right? CMS strongly emphasizes evidence-based intervention for patient safety, period. No ifs, ands, or buts, including pressure injury prevention. Conditions of participations for hospital must use validated tools and intervention to prevent harm. Reading that alone, we're done. I'm not doing anything. This is not acceptable to the CMS, right? But wait, quality reporting program tools that are not widely validated may raise question if outcomes are reported to CMS. But we're only doing prevention. We're not doing treatments. That's my take, right? CMS generally expects tools and intervention used for quality measurement or reporting should be validated and evidence-based. We're done. It wants evidence-based, ideally with peer-reviewed or published evidence. However, using hospital-validated tools as per CMS, there are some consideration that we can actually do this. Key consideration, validation rigor. Have you tested it? How large enough was your sample? Was it prospective? Was it retrospective? Transparency. You document your method. You document those people involved who are in the beginning of this program. Who were the person? What are their roles in making this tool? The threshold, the sensitivity and specificity, alignment with standard. Even local tools should reference evidence-based principles of Braden, PUPI. So we know all our preventions are the same with Braden. We have beds, we have return the patient, we do pre-dressing. Those are the same principle. Then regulatory disclosure. You let them know. If surveyor or CMS comes to your site and asks, what have you been using to reduce your number? You explain it is an internally validated. You describe the outcome and that it will show that it is safe and effective. So the prevention protocol that you're gonna add in your validated tool should be low risk or zero risk to patients' safety, because that's number one, patient safety. So when you're doing on something along with your tool that had the intervention piece of it, it should be safe for the patient. So the product that you're going to use should have had extensive research that is safe for use. So use for internal risk stratification. So you are allowed to use not evidence-based, but you will document it as evidence-informed because that's your own hospital's validated tool. So potentially acceptable in CMS context if it's not used for public reporting. We are not using reporting. We're not using it for public reporting because we are using it for prevention. So like any prevention and any tool that you're gonna start on your hospital or whichever facility, you do the procedure, you evaluate it, and then you change it if it doesn't work, or you update it. That's why the evaluation needs to happen. So talking about prevention-driven tools or bundle, not all foam dressings are alike. There are frictional energy that we want to consider on using or choosing our foam dressing. In my practice, I have evidence because of a live in life, because that's the product I use. What's unique about this product is the unbonded layer. When you have 5 layer foam dressing, okay, great, there is cushioning. But does it address friction? Because you wonder, I have a 5 layer foam dressing. It's also silicone foam dressing. It doesn't strip the patient's skin. But I wonder, why do I have a DTI? Because during frictional energy, it does not absorb this friction because it's bonded. So when the layers are unbonded, it will slide on its own. It will absorb the shock of the frictional energy, and it doesn't even touch the heel because the energy, as it goes through those layers, it reduces its impact because it's already is absorbed. So not all foam dressing are the same. So you have to select those foam dressing that might you think is good for your patient, which is unbonded. So, conclusion: preventing pressure injury in cancer care requires more than a score. It requires a shift in thinking, assessment, and action. So I would like to ask anybody for any question.
Thank you so much, Lilibeth. This was such an interesting conversation and very methodical too. Thank you so much for presenting it very clearly for us as well. We've had some great comments come in here, so I'll try to summarize it a little bit. Highlight a couple different themes in the chat and remind everyone here, if you have any thoughts, ideas, suggestions, whatever, feel free to use that chat tool or the Q&A one if you have any specific questions. So many clinicians were saying that the Braden score often confirms what they already know, but after the fact, especially when it's done quarterly. So several pointed out that it doesn't capture systemic pathology or underlying diagnosis that really drive risk across long-term care, rural geriatric settings, spinal cord injury, and mobility limited populations. People are caring for patients who are constantly at high risk, so they're relying heavily on full head-to-toe assessments and clinical judgment. One long-term care team mentioned that they include the latest Braden score on transfer forms, on hospital transfer forms to flag early risk, or to, sorry, flag the risk early. Also hearing from some people who are working with wheelchair users who see pressure injuries in almost every case because of the prolonged sitting, of course, limited offloading. Someone raised an important gap that advanced support surfaces tend to only be recommended at the high risk level in Canada. And we focus heavily on mattresses, but this person was mentioning that many patients spend the majority of their day sitting, and they find that in the US, skin protection cushions are often recommended at even moderate risk. There's a sense that we need to reassess how we think about sitting surfaces too as a core part of the prevention piece. And I wonder if maybe if you wanted to touch on that, I'm sure from the U.S. perspective too, are you finding that interventions coming in, or that those kind of devices for sitting are being recommended earlier, or not earlier, but in the moderate level, not just at high risk?
Yes, it should be. It is always recommended before any skin breakdown. We use bed as prevention. We don't use it as treatment when there's already
Hmm.
a breakdown. And you made mention about the wheelchair sitting the patient.
Hmm.
That's We encourage patient to be out of bed when applicable, when the patient have good upper body support. So in this situation, when the patient is sitting, cushion is okay. Prevention dressing is excellent. And you know what I find out on those patients that's sitting on a wheelchair? I think it's relevant that you shift their sitting position from side to side every hour rather than every 2 hours. So there is a way actually to relieve the pressure of one buttock at a time by shifting them while sitting up. But these are the patients that should have a good upper body support. Early bed placement should be mandatory for patients. That's why Braden scale, I admire them putting Braden scale aside and just looking at the patient. And oh, this patient is high risk, let me just not even counting Braden. So you see the need of the Braden scale, that they are just using it monthly or quarterly. So it's irrelevant now what Braden says, because our nurses knew that their patient have this kind of risk. But to in order for you to fight why I need a bed, there had to be a tool to address it. because then you are fighting like, I need a bed, the patient is high risk, but you're not gonna, your leadership might not be able to approve you renting a bed. It really depends on the hospital, but some hospitals or leadership just agrees with a bed because you felt the need that the patient should have a bed. I give my nurses liberty to decide if the patient needs a bed and doesn't need my opinion, but it really depends on your place. Some place do need a validated tool that should tell them the patient needs a specialty bed. And that's where this comes in. That's where we need this preventive tool. So it should be prevention driven, using pre-dressing, using a pressure relief bed or a cushion or a shifting. So it's that would really help them agree why you need a bed early on.
Absolutely. And one person was mentioning here, I think also, especially in long-term care as well, but it'd be nice to have dementia or that the dementia piece included as well. Someone was mentioning this is a very good refresher and very well done. So thank you. People are mentioning those who are elderly or have a disability or paralyzed patients. Tina was asking, when you say need a bed, do you mean a pressure injury relieving mattress? Is that what you're referring to?
Yes.
Yeah.
It doesn't need to be a pressure redistribution, but it's a pressure relief. So those are two different things. One is
Mhm.
moderate, one is a high end type of bed. We have different types of bed, but pressure relief should be a must do for all patients. That is have deconditioning. But then again, your facility might not agree it's too expensive. That's why they rely heavily on tools, on risk assessment scale, and seeing this nurse's mind thinking about elderly and long-term care, they're desperate of help as
Mhm.
far as prevention tool. I think that's
Uh,
another avenue to look into, honestly.
Absolutely. And one person mentioned a little bit early on in the presentation, I see Anna's actually bringing up the point I was just about to make here too. One is about involving the nutritionist or a dietitian, both in the cancer-related nutritional issues and its impact on skin integrity, but for pressure injuries in general. And someone is mentioning again, reiterating what you're saying, a key reminder that cancer patients aren't just in the hospital; they're in the community, they're at home, they have have caregivers, they have spouses, they have other people with them too. So just a reminder, but yeah, assessments, prevention strategies need to reflect those settings as well, involvement of
Yeah.
other people. And Anna's going further here to say the importance of collaborating with OTs and PTs, who are prescribers of that assisted technology as well. Yeah, great point. Um, yeah, lots of great comments going in here now too. You
Yeah.
really got the discussion going. Involving the
God.
multidisciplinary team is a key approach. OTs for pressure mapping. Yeah, did you want to just speak again to their overall that team approach too? That the importance, of course, of having the research side, even as we were saying, but also making sure it's the people at the bedside every day. It's the nurses who are being able to adapt, to inform all these kind of things that are happening. I'll pause for a second. I'll let you just digest what I've been saying there, but lots of great comments coming in.
Yes. I really noted that our oncology patient is not in the hospital. That's why Braden Scale don't agree with them. They are at home. They're living their lives. And our nurses visit them once, twice a week. It really depends on the need. If they have wound, they visit 3 times a week. That's why we need to get everybody involved. Even though they are at home, we have a team of doctors. We have labs. We can do labs routinely. The nurse or the COC, we call them, is the clinician on the patient, the care manager of the patient, which is an RN, comes to visit and say, we're going to need to check labs. And usually, with your physician on board, agrees with that one and had to be ordered. So even though they're at home, you have an interdisciplinary team taking care of the albumin level, the anemia. Even though they are cancer, they're not dying. They didn't sign for no labs, no all of this. So even though they're at home under your care, because we have visiting nurses, we have oncology nurses coming to home. These are the things that the buy-in of everybody should be in it. PT, OT, we need MD, we need nutritionists, we need wound care nurses. They have to visit the patient at least once in 3 months.
Absolutely. And some other comments that people are messaging here that some of the pressure injuries they've seen aren't just coming from immobility or the bed. It can be caused from mechanical devices, splints, orthotics, even ill-fitting shoes potentially too. So,
Yeah,
um,
that's
yeah,
device
so
related.
absolutely. And someone is suggesting, yeah, maybe the next or a new assessment tool or an adaptation should be developed with OTs, with PTs, with that interdisciplinary team that we were mentioning. So I'm going to use that as a quick way to also mention CPIAP for a quick second. For those who aren't aware already, the Canadian Pressure Injury Advisory Panel is trying to address pressure injuries across Canada. We want to be the national issue or be the national voice of pressure injuries in Canada. It's interprofessional nationwide panel, and it's represented by a cross section of clinicians, researchers from a whole different areas of the country. And tomorrow we're having a hybrid, so both in person and online pressure injury summit. It's free to register for it. As I said, it's going to be available virtually if you aren't available to come. It's in Ottawa, Ontario at Carleton University. We are also recording the sessions tomorrow. Just because I know that with last minute notice, there'd be very difficult to take the day off at this point, of course, but we will have that available, and it could be a great opportunity if you are planning to go in person to bring up some thoughts that you had if you are coming to Ottawa. But share it online as well tomorrow too. Be a part of that chat, be a part of that nationwide conversation, whether it be oncology related or elsewhere. It's important. So. I know we've got a couple more minutes here too, and I see you've moved over to your slide. If you want to get in touch, I'll let you maybe say how people can get in touch with you, and we'll see if more comments come in the meantime.
Yeah. So this is, you have my number over here and my email. If you have question or if you have any suggestion, I would like to hear your input. This is a community of experts, and we have so much talent that we want to hear from you rather than later. Maybe if you have anything that you can share, would really appreciate that. And yeah, I'm here to support everybody, and we can work together on putting in something.
Absolutely. Well, I really appreciate you bringing this forward, and it's a great that we've had a chance for you to speak again. NSWOCC here is also mentioning that the CSMC conference takes place every year, so that'd be another good opportunity to discuss this. Now, again, I want to thank you so much because it's a new style of webinar that we're doing too. You're bringing a really interesting approach that challenges the way that we're thinking about things, the way that we're assessing, the way that we're working with our patients or for our patients and clients. So thank you so much for doing this. It's a great topic of conversation. I hope everyone online does get a chance to reach out if they have some ideas. If you want to get more involved in Canada specifically, CPIAP, it is free to become a member. It's at the moment we're really trying to do quite a number of things, but it takes getting voices to the table, as I'm sure you can appreciate as well, Lilibeth. It takes a big team to get some of these ideas moving forward. So
Yeah.
from that point, I'm going to say also thank you to Smith+Nephew for making today possible. We really appreciate your partnership. They'll be joining us tomorrow at our summit as well. And so we can't wait to have another webinar, another opportunity to do some education with Smith+Nephew. I can't say thank you enough, Lilibeth. So I hope
Yeah,
you
thank
enjoy.
you, everybody.
I hope
I
you
hope
enjoy.
it opens up an avenue for everybody to, interest on putting on something for cancer patients. I don't care where. I hope it's in Canada. That's going to be the next breakthrough for this. So really, we can work together in this one. Reach out to me, and I'm really willing to work with you, do research, whatever you need from me. And you have your number, you have your patients, you can tell me what's going on, and we can put something together. We'll see. It's really a very dear topic for me. I've always have advocacy for pressure injury, but especially this patient, the cancer
Mhm.
patient, that's always at the back burner of the big and obvious topic for pressure injury. So I want them front and center and given the right acknowledgement of their uniqueness of this patient.
Absolutely. And maybe you, as someone online, might know someone who's also very involved, sees this as an issue that they want to be more involved with too. We're going to be posting this recording, as I mentioned at the beginning. The recording will be available on our website. It'll probably be Monday, Tuesday by the time I get the chance to edit it, but we will have that available. You're welcome to share it widely. We want to make sure, as you're saying, Lilybeth, everyone who thinks they can make an impact has that opportunity. So stay tuned for an email from us on Monday or Tuesday. And otherwise, I hope everyone has a great night, a great pressure injury prevention day or worldwide pressure injury prevention day.
Thank you.
And we'll be in touch with everybody soon.
Thank
Bye.
you, everybody. Good night.